Hello, my name is Dr. Cora Sternberg. I'm the clinical director at the Englander Institute for Precision Medicine at Weill Cornell Medicine in New York, New York. I'm going to speak to you today about the evolving role of antibody-drug conjugates in the treatment of urothelial carcinoma. Beyond checkpoint inhibitors, what is the role of antibody-drug conjugates in metastatic urothelial carcinoma? In terms of bladder cancer globally in 2020, there were almost 600,000 new cases of bladder cancer. Bladder cancer was the 10th most commonly diagnosed cancer and the 6th most commonly diagnosed in men. Bladder cancer was responsible for over 200,000 deaths. 90% of bladder cancer is urothelial carcinoma. But metastatic urothelial carcinoma is only perhaps 5% of the bladder cancer that we see. But the 5-year survival for metastatic disease is only 6.4%. Cisplatin is the standard treatment in metastatic urothelial carcinoma. However, 50% of patients are often considered ineligible, either because they're elderly, have poor performance status, poor renal function, neuropathy. There are many different reasons for this. And we think that carboplatin has inferior outcomes when compared to cisplatin. The problem is that since we developed the MVAC chemotherapy regimen in the late 1980s, there really has not been much progress until very recently when we developed immunotherapies and antibody-drug conjugates. And the field is really exploding in a very positive way, I would say, right now. So if a patient is PD-L1 positive, immune checkpoint inhibitors are now an option. But even then, some 70% of patients don't respond and will require further treatment. Now, antibody-drug conjugates are a new approach in metastatic urothelial cancer. We see a monoclonal antibody, the tumor cell surface has an antigen. The monoclonal antibody attaches to the antigen, and there's also a linker that is linked from the monoclonal antibody to either a cytotoxic drug or radionuclides. And in this way, the linker is able to bring the cytotoxic drug directly to the tumor cell. So monoclonal antibodies, as I mentioned, are conjugated to cytotoxic drugs or radionuclides. This improves the potency and effectiveness of the monoclonal antibodies and allows for a targeted delivery of a toxic payload to tumor cells. This minimizes the nonspecific systemic toxicity. Here you can see there's external drug release leading to a kind of bystander effect, and there could be immune cells brought in because of this bystander effect. There's antigen binding of the monoclonal antibody that through endocytosis is taken into the cell. There's endosome formation, lysosome tracking. Once the lysosome is then degraded, there's drug release. And then the drug binds to the intracellular cancer cell target. Enfortumab vedotin is an antibody-drug conjugate that has been approved for urothelial carcinoma. The target is Nectin-4. This is a transmembrane cell adhesion molecule that's highly expressed in cancer cells, including urothelial carcinoma. It's linked to monomethyl auristatin E, which is a microtubule inhibitor. That's what we call the payload, what actually kills the tumor cell. There was FDA full approval in July 2021 for adult patients with locally advanced or metastatic urothelial cancer who have previously received a PD-1 or PD-L1 inhibitor and platinum-containing therapy, or who are ineligible for cisplatin-containing chemotherapy and have previously received more than one prior line of therapy. Another antibody-drug conjugate for urothelial carcinoma is sacituzumab govitecan. The target is TROP2, a cell surface antigen that's highly expressed by many cancers, including metastatic urothelial carcinoma. Here, there's a cleavable payload. The payload is SN38, a topoisomerase inhibitor payload, and this is the active metabolite of irinotecan. There was FDA accelerated approval in April 2021. Adult patients with locally advanced or metastatic urothelial cancer who have previously received a platinum-containing chemotherapy and either a PD-1 or PD-L1 inhibitor. By accelerated approval, it means that it is now available, it's on the market, but we are waiting for confirmatory trials to get full approval. So if we look at the NCCN treatment guidelines, the preferred regimens for cisplatin-eligible patients are gemcitabine and cisplatin, followed by avelumab maintenance, or dose-dense MVAC with growth factor support, followed by avelumab maintenance. This is a result of the Javelin 100 bladder study, in which patients received 4 to 6 cycles of gemcitabine and cisplatin or carboplatin, and then went on, if they had CR, PR, or stable disease, to receive avelumab maintenance every 2 weeks as compared to placebo. For those patients who are cisplatin ineligible, gemcitabine and carboplatin with avelumab maintenance, or there's the alternative of pembrolizumab or atezolizumab for patients who are PD-L1 positive only or not eligible for any platinum chemotherapy. Second-line treatment options, according to the NCCN treatment guidelines, the preferred regimen at the moment is pembrolizumab. Alternate preferred regimens are immune inhibitor checkpoints such as nivolumab and avelumab. These have been approved and gotten full approval after having accelerated approvals after the Javelin 100 study for avelumab, and nivolumab after the Checkmate study, in which it was proven to improve PFS in the adjuvant setting. Erdafitinib is a drug that is used for those patients who have FGFR3 or 2 genetic alterations, which we see most often in patients with upper tract urothelial carcinomas. And then, again, enfortumab vedotin is another alternate preferred regimen in second line. Post-checkpoint inhibitor for those patients who are chemotherapy naive, according to the NCCN treatment guidelines, the preferred regimens for cisplatin-eligible patients are gemcitabine and cisplatin with dose-dense MVAC with growth factor support. And for the preferred regimens for cisplatin-ineligible patients are enfortumab vedotin or gemcitabine and carboplatin. That's after having received and checkpoint inhibitor and being chemotherapy naive. If we look further at the NCCN treatment guidelines for subsequent lines of treatments, the preferred regimens are enfortumab vedotin, erdafitinib for those patients with FGFR3/2 genetic alterations, and other recommended regimens include sacituzumab govitecan, as I mentioned, which has accelerated approval at this time. In terms of the ESMO treatment guidelines, enfortumab vedotin is a recommended treatment option in patients who have relapsed after first-line single-agent immunotherapy. It's recommended as standard treatment in patients with chemotherapy and immunotherapy relapsed disease. Enfortumab vedotin is not currently EMA approved, however. So in conclusion, patients who progress on chemotherapy and immune checkpoint inhibitors have a poor prognosis. Antibody-drug conjugates pair a potent cytotoxic drug with an antibody which targets only the cancer cells. Antibody-drug conjugates could fulfill an unmet need for treatment in patients who will not benefit from chemotherapy or immune checkpoint inhibitors. This talk is about improving outcomes with antibody-drug conjugates in urothelial carcinoma. Where are we now, and what are the next steps? If we look at the phase 2 study of enfortumab vedotin, Cohort 1 had 125 patients. Enfortumab vedotin was given on days 1, 8, and 15 of a 28-day cycle. Patients had locally advanced, unresectable, or metastatic urothelial carcinoma, and they were previously treated with a PD-1, PD-L1 inhibitor and platinum-based therapy. In the smaller cohort 2, there were locally advanced or unresectable metastatic urothelial carcinoma. These patients were platinum naive and cisplatin ineligible, and they had prior treatment with the PD-1, PD-L1 inhibitor only. That's cohort 2. So the primary endpoint is confirmed overall response as determined by blinded independent review. And if we look at cohort 1, the patients who had received cisplatin, there is 125 patients. The overall response rate is 44% with a complete response rate of 12%. That's pretty good, actually. And also cohort 2, the overall response rate is 51% with a complete response rate of 22%. The secondary endpoints in this phase 2 study, I think the most important is perhaps the overall survival. In cohort 1, the median follow-up is 10.2 months, but the overall survival 11.7 months. And in cohort 2, with a median follow-up of 16 months, the overall survival is 16.1 months. This is the study design of the registration trial, EV301. It's a phase 3 study of enfortumab vedotin. 608 patients were included with locally advanced or metastatic histologically or cytologically confirmed urothelial carcinoma. They were previously treated with platinum-containing chemotherapy. They had an ECOG performance status of less than or equal to 1, and radiographic progression or relapse on or after PD-1 or PD-L1 inhibitor treatment. Patients were randomized 1-to-1 to enfortumab vedotin given days 1, 8, and 15 of a 28-day cycle, or the investigator's choice of chemotherapy, which was docetaxel, paclitaxel, or vinflunine in Europe, because that is not approved in the United States. And if we look at the study design, again, patients randomized between enfortumab vedotin, investigator-chosen chemotherapy. The primary endpoint was overall survival in this study. And you can see here the overall survival at the interim analysis. Enfortumab vedotin improved overall survival by 30% versus chemotherapy. The hazard ratio 0.70 at a median follow-up of 11.1 months. The median overall survival with enfortumab vedotin was 12.88 months, and with chemotherapy, it was 8.97 months. We look at secondary endpoints such as the median progression-free survival. Again, in enfortumab vedotin, it was 5.55 months as compared to chemotherapy, where it was 3.71 months. And the overall response rate with enfortumab vedotin was 40.6% with a CR rate of almost 5%, as compared to chemotherapy that had an overall response rate of almost 18% and a CR rate of 2.7%. This is the study design of the phase 2 study of sacituzumab govitecan. Again, these are patients with histologically confirmed locally advanced or metastatic urothelial carcinoma, a good performance status. We have cohort 1, which is the largest cohort with 113 patients. These patients progressed after prior platinum-based and or immune checkpoint-based therapy. And then the smaller cohort 2 of 22 patients that were ineligible for platinum-based therapy, and they progressed after prior immune checkpoint inhibitor-based therapy. These patients all received sacituzumab govitecan on days 1 and 8 of a 21-day cycle, and the primary endpoint is confirmed overall response as determined by blinded independent review. You can see here the primary endpoint. The overall response rate with sacituzumab govitecan is 27%, with a complete response rate of 5%. Median follow-up is 9.1 months. And with cohort 2, the overall response rate is 29%. Secondary endpoints in this phase 2 study most important, I would say, would be the median overall survival in cohort 1, the more heavily pretreated patients with a median follow-up of 9.1 months. The median overall survival is 10.9 months. And in cohort 2, the platinum ineligible patients, the median overall survival is 11.1 months. So what's going on now is a phase 3 study called TROPiCS-4 of sacituzumab govitecan. 600 patients will be randomized, patients with locally advanced or unresectable metastatic urothelial carcinoma. They will have progressed after platinum-based therapy and immune checkpoint inhibitor therapy, and randomized 1-to-1 to either sacituzumab govitecan given as usual in days 1 and 8 in the 21-day cycle, or the physician's choice of chemotherapy, again, docetaxel, paclitaxel, or vinflunine in Europe, where this is not approved in the United States. The primary endpoint of this study is overall survival, and the estimated completion date for this study is January 2024. Let's look at future directions with enfortumab vedotin. There's an ongoing study that should include 760 patients who have locally advanced or unresectable carcinoma. This is a first-line study of a combination of enfortumab vedotin and pembrolizumab as compared to gemcitabine and either cisplatin or carboplatin. And we've seen very good results of patients that were platinum ineligible with this combination of enfortumab vedotin and pembrolizumab, first presented at ESMO by Holmes and then later presented by Rosenberg at ASCO GU. The primary endpoints are progression-free survival by per RECIST by blinded independent review, and also overall survival. And the future directions for sacituzumab govitecan, we still have further cohorts in the TROPHY-1 study. Cohort 3 is for patients that are checkpoint naive and have progressed after prior platinum-based chemotherapy. They're receiving a combination of sacituzumab govitecan and pembrolizumab. And cohorts 4 and 5, these are patients that are platinum naive, but not refractory to platinum-based therapy in the neoadjuvant setting. And they will be randomized between sacituzumab govitecan and cisplatin as compared to sacituzumab govitecan and cisplatin, and then avelumab. So other future directions include HER2 targeting antibody-drug conjugates. HER2 is expressed highly in breast cancer. It's also expressed highly in gastric cancer, and in quite a high proportion also, and probably not as well known, in urothelial carcinoma. So this anti-HER2 antibody called disitamab vedotin has the same payload as what we saw in enfortumab vedotin, the microtubule inhibitor, MMAE. In disitamab vedotin, 43 patients were treated in a phase 2 study. These were patients that were HER2 positive with locally advanced or metastatic cancer, and they'd failed at least one line of systemic therapy. At a median follow-up of 20.3 months, the overall response rate is 51.2%. And that is the primary outcome for overall response rate. They're also investigating this antibody in patients that are HER2 negative and have locally advanced or metastatic urothelial carcinoma. Another antibody is trastuzumab deruxtecan. The payload is deruxtecan topoisomerase 1 inhibitor. Again, it's an anti-HER2 antibody. And there are a few trials going on. The Destiny Pan-Tumor 2 trial, which is a phase 2 HER2 positive trial for solid tumors, and cohort 2 is for patients with bladder cancer. And there's a phase 1 trial in combination with nivolumab in advanced breast and urothelial cancer. Cohort 3 will have advanced metastatic urothelial cancer with immunohistochemistry 2+ or 3+ positive for HER2 expression, and cohort 4 will be advanced urothelial cancer with HER2 expression that's only immunohistochemistry 1 and progression on prior platinum-based therapy. Other antibody-drug conjugates targeting HER2 under investigation include MRG002, again with MMAE payload, trastuzumab, emtansine with a DM1 payload, and there's trastuzumab duocarmazine, which has a duocarmazine payload in a study that's phase 1 in a variety of solid tumors. TROP2 targeting is also under investigation. There's the ST13258 study, SN38, again, the payload that we saw in sacituzumab govitecan, which is the active metabolite of irinotecan. The same payload is being used in another study that's phase 1/2 in solid tumors called ESG4012. And then there's another study called SKB264, where vedotin-derived payload is being employed. There's also antibody-drug targeting against FGFR3. And in this study, ravtansine or DM4, again, is a maytansinoid. And there's a phase 1 study in advanced or metastatic cancer, including urothelial carcinoma. In conclusion, enfortumab vedotin significantly prolonged survival versus chemotherapy in patients with locally advanced, unresectable, or metastatic urothelial carcinoma. This was the first interim analysis, and the study was stopped, and all patients in the chemotherapy arm were allowed to then cross over to the enfortumab vedotin arm. Sacituzumab govitecan showed notable efficacy in patients with metastatic urothelial carcinoma who have progressed on prior platinum-based chemotherapy and immune checkpoint inhibitors in phase 2 trials, and a phase 3 trial is ongoing. Several antibody-drug conjugates have been approved for other tumors, are being studied in patients with urothelial carcinoma, with many emerging antibody-drug conjugates in early development. I'm going to speak to you about optimizing the safety of antibody-drug conjugates in urothelial cancer. What are the possible adverse events, and how do we manage them? There are safety considerations when we are dealing with antibody-drug conjugates. Immune reactions to antibody may lead to infusion-related reactions or mild allergic reactions, even to anaphylaxis. And when these drugs are infused, they should, at least the first time, be infused very slowly to make sure people are not allergic to the drugs. If we look at the drug to antibody ratio, in enfortumab vedotin, it's 3.8 to 1, and in sacituzumab govitecan, it's 7.6 to 1. And they have cleavable linkers that have the potential to prematurely release the cytotoxic payload. Some of this might be good if it's released in the immediate microenvironment of the tumor. It may not be a bad thing. So if we look at enfortumab vedotin in the 301 study, you can see that any grade treatment emergent adverse event occurred in almost 94% of patients. And this led to dose reductions and dose interruptions. The most common were peripheral neuropathy, alopecia, some fatigue, maculopapular rash. The ones of special interest are the skin reactions and peripheral neuropathy. These are the ones that have disturbed my patients the most. I've seen anything from blistering skin reactions to peripheral neuropathy, in which patients really even cannot feel their feet. They love being on this drug and they don't want to stop the drug. And sometimes I have to lower the dose, and I have to take them off the drug because of peripheral neuropathy. It can become a problem if patients are on long-term on this drug. So we need to closely monitor for skin reactions. And if patients develop a Stevens-Johnson syndrome or toxic epidermal necrolysis, this is very serious. And this could occur during the first cycle or even later. And obviously the drug needs to be stopped if this occurs. For most skin reactions, you can treat with topical corticosteroids and antihistamines as clinically indicated, and modify the dose. And here you can see in this table different dose modifications for skin reactions. And if they develop Stevens-Johnson or toxic epidermal necrolysis, you need to permanently discontinue the drug. For peripheral neuropathy, We need to ask patients about peripheral neuropathy. Do they have tingling in their feet? Do they have problems walking? How do they feel? Sometimes the patients won't tell you, but we really need to monitor carefully and think about dose modifying if this does occur. And here are some of the dose modifications for peripheral neuropathy, as you can see in the table. If they're more than grade 3, we need to eventually permanently discontinue the drug. For ocular disorders, we should monitor patients for signs of any ocular disorders, such as vision changes. And I've found that eye drops are useful. We can give prophylactic artificial tears or have them see an ophthalmologist and use topical steroids after an exam or modify the dose as well. And here again, you can see the dose modifications for ocular disorders and permanently discontinue for grade 4 disorders. Now, if there's infusion site extravasation, a reaction may occur. Need to stop the infusion and monitor for adverse reactions. For patients with hyperglycemia, it's more often seen in patients who already have diabetes or at high risk for hyperglycemia. This needs to be monitored carefully. You need to manage hyperglycemia as we normally would with anti-hyperglycemic medications as indicated, and reinforce adherence both to the medications and to eating a regular diet. And don't treat anyone if their blood glucose is more than 250 milligrams per deciliter. You can resume treatment when it's below that level. We need to also monitor for pneumonitis. Patients can have signs of symptoms of hypoxia, cough, dyspnea. We need to evaluate and think about infectious causes, neoplastic and other causes, but pneumonitis can occur with enfortumab vedotin. And here are the dose modifications that are recommended. Permanently discontinue if more than grade 3. Regularly monitor also for the CBC of your patients before each dose. Dose modify if this becomes a problem. And here you can see in the table, once again, the dose modifications that are recommended. And if that's grade 4, withhold until less than grade 1 and reduce by 1 dose level or discontinue treatment. With sacituzumab govitecan, any grade treatment emergent adverse event was also seen in some 95% of patients. And you can see here that the events are a little bit different. We're not talking about skin or peripheral neuropathy. Here we're talking more about diarrhea, nausea, fatigue, and leukopenia is an important side effect. So you need to monitor the neutrophil counts and temperature for signs of fever. And patients who are known to have reduced UGT1A1 activity should be monitored closely for severe neutropenia. Remember, this SN38 is the active metabolite of irinotecan, and those patients who have reduced levels of this enzyme have problems with irinotecan and will have problems also with this drug as well. So neutropenia is very important to monitor, especially in these patients, and reduce the dose in patients who have low levels. If neutropenia presents on the first day, consider G-CSF, and if it presents on day 8, also G-CSF is often used, and you may need to modify the dose, particularly in patients who lack enzymes. And here you can see in this table, depending upon when the neutropenia occurs, how you should dose reduce the drugs to 25% or to 50%, or whether or not you should discontinue treatment altogether. To monitor for hypersensitivity and immune-related reactions, they can include severe anaphylactic reactions, and they usually have been observed within 24 hours of dosing. So you need to monitor patients. When we give this to our patients, on the first dose, we give it very slowly. And then if they have no reactions at all, we can give the dose much more rapidly on subsequent doses. And we can mitigate these kind of reactions with pre-medications and antipyretics and corticosteroids as needed, and then dose modifications. You need to monitor for diarrhea and cholinergic syndrome in patients on sacituzumab govitecan, if they have abdominal cramping or diarrhea, but you should also make sure that there's no infectious cause of the diarrhea. And here you can see some of the recommendations on how to treat the diarrhea. If it's a late onset, they recommend loperamide. And there's many different ways. Be sure that the patients have adequate fluids when they have diarrhea. Monitor for nausea and vomiting during or shortly after the treatment of scheduled treatment. And if patients do develop chemotherapy-induced nausea and vomiting, you can pre-medicate them with 5-HT3 antagonists and dexamethasone on day 1. Additional NK1 antagonists can also be considered. And there are other drugs that can be used for persistent nausea, as well as dose modifications. And here you can see, again, depending upon the grade, how you should modify the dose for non-haematologic toxicities in general. So enfortumab vedotin in combination with pembrolizumab, as we said, is a very active combination. Peripheral neuropathy that we've seen from enfortumab is seen. This is a study of 45 patients. Fatigue, alopecia, some diarrhea, and macular and papular rash. There was one treatment-related death reported. So in conclusion, there are common treatment emergent adverse events associated with antibody-drug conjugates. Healthcare professionals must be aware of which treatment emergent adverse events may occur to monitor for and manage them throughout the treatment course. Antibody-drug conjugates in combination therapy appear to be tolerable. Thank you very much.